Now we will have the second talk regarding DOACs and bleeding. It's my pleasure to introduce Sarah. Thank you very much.
Thank you, Professor Cohen. I'm pleased to present you the management of bleeding on DOACs. So let's start with diapositive.
Can we have the first? Thank you.
Okay, thank you. So the first point to assess when a patient comes with a bleeding on DOACs in the emergency department is to assess the severity of bleeding. Is it a mild type of bleeding? Is it a moderate to severe bleeding? Or with a patient who is hemodynamically stable and outside an anatomically critical site? Or is it a severe and life-threatening bleeding with a patient who is unstable, maybe in hemorrhagic shock, and in a bleeding which can rapidly compromise an organ function? Another second point is important to assess is the patient's medical history. Outside the question which dose the patient has and the indication, which give us information about the dose regimen, the time of last administration is an important point. Comorbidities of the patient, which can increase or cause bleeding, is important to assess. And co-medication. Is the patient on antiplatelets? Does he receive anti-inflammatory drugs or any drugs that prolong DOACs' half-life? So renal function, of course, is important, as you can see with dabigatran and 80% of kidney elimination. And if possible, it's important to know the residual plasma concentration of DOACs. Is there clinically relevant or non-relevant plasma concentration? What are the general measures that you can do for all the patients? First is to stop, of course, the DOAC. That can be sufficient for mild bleeding, and local hemostasis also first point to do. When you have a bleeding that can be moderate, you can think about what hemostatic procedure can help. Endoscopic maybe, endovascular, invasive procedure like surgery or packing. You will not forget to give fluid to the patient to avoid hypovolemia and maintain diuresis. Correct acidosis, hypothermia and hypocalcemia, and correct other causes of bleeding. Hypertension is important in case of intracranial bleeding to control hypertension below 140 millimeter of systolic blood pressure. Liver failure, vitamin K deficiency, stop co-medications that can increase bleeding, that is also point to assess. Active charcoal can be, of course, given when the patient has a recent intake of DOACs. It has been published up to 6 hours after the apixaban uptake, and in case of overdosage, that can be an important place. Hemodialysis is only for dabigatran because he has a low protein binding. Of course, if the patient is already anemic or is bleeding moderate to severely, you can think about blood products, transfusion, like red blood cells, platelets, and plasma, fresh frozen plasma, but not as a reversal therapy, but more as a plasma expander. Antifibrinolytic drugs can be used as adjuvant treatment for bleeding, of course. What do we have for antidotes or non-specific reversal therapy for the DOACs? We have for dabigatran a specific antidote that is now currently available. This antidote is known as Praxbind and or idurizumab, and it is administered with a bolus of 2 vials of 2.5 grams in 5 to 10 minutes. It has a high cost, of course, and it is important to justify to want the administration of this antidote. If you don't have this antidote, then you can go to non-specific reversal therapy, like protamine complex concentrate, 25 to 50 units per kilogram with a supplementary dose of 25 units per kilo, or activated concentrates, 30 to 50 units per kilogram with a maximum dose of 200 units per kilo. Recombinant factor 7 is only proposed when it's really a disparate situation. For direct anti-10 anticoagulation, there is a specific antidote which is the andexanet alpha. It works also on fondaparinux and low molecular weight heparin. For the moment, the only market authorization is from the FDA and only for bleeding and only for rivaroxaban and apixaban, as it's only the molecules that has been studied for this indication. So bolus and from 15 to 30 minutes followed by infusion of 2 hours is necessary because after the bolus there's an increase of anti-10 activity. This can be also happen. This can be also found after the infusion of 2 hours. Therefore, we have to be careful, and we are not sure that rivaroxaban, apixaban is safe in other situations. So we need to study that more. Different dose schemes are also proposed that can make this use difficult. For the moment in Europe, we don't have the market authorization for andexanet alpha. So what we have for patients who have severe to life-threatening bleeding is, again, like dabigatran, PCC, APCC, with the same doses. These medication drugs are, of course, reserved for severe to life-threatening bleeding. Hemodynamic instability with a clinically relevant plasma concentration that warrants antidote administration is considered by experts over or equal to 50 nanogram per ml. But this is, of course, not, that has not been many evidence to prove that this threshold is enough. So the important question is, of course, what is the impact on the outcome of the patient? So why and how to assess residual plasma concentration of DOACs? First, of course, is to want antidotes administration. So, of course, do not wait for results in life-threatening bleeding such as intracranial hemorrhage or ruptured aortic aneurysm. You don't have time for it. But the fact you have it's before antidote administration helps you to treat the patient afterwards and to know where you're going. Because the second important point is the follow-up after antidote administration. Some patients will be in supratherapeutic levels, and that can justify a second dose of antidote. Some patient will also have an renal failure, important renal failure, and you can see a rebound effect after antidote administration at 12 to 24 hours after idurisuzumab, for example. And of course, if the patient is rebleeding after antidote administration, you will have to consider if there's still a residual impact of DOAC. What do you have for laboratory tests to assess these DOACs? We're talking now about routine tests with sensitive reagents. It's important because there's many reagents that are available, but here we will talk about sensitive reagents. So for dabigatran, thrombin time is very sensitive to the presence of dabigatran. So if it's normal thrombin time, you can exclude clinically relevant presence of dabigatran. APTT, so activated partial thrombin presence time, is also sensitive to dabigatran, but if it's normal, you cannot exclude clinically relevant plasma concentration of dabigatran. For rivaroxaban, edoxaban, you have the prothrombin time. And unfortunately, for apixaban, even very sensitive prothrombin time are not always cannot always exclude clinically relevant presence of apixaban. Therefore, it's important to have specific tests. I would talk about a standardized specific test that can be easily implemented in laboratories. For dabigatran, you have the diluted thrombin time and the current chromogenic assays. For rivaroxaban, apixaban, and edoxaban, you have specific anti-10A assays, which are calibrated for each specific anti-10A.
Thank you, Sarah. Thank you very much. Such an interesting topic. Well, I have numerous questions regarding the importance of this topic. And the first one is related to the last slide you have just presented. So, in other words, precisely how to manage bleeding when you do not have any specific test, as unfortunately it's the case in numerous hospitals around Europe.
Thank you for this question. Of course, experts already say that it's important to manage emergencies on DOACs to have specific tests, but many laboratories don't have them. So how to deal with routine tests? First question is, what is the last time of administration of the DOAC? If you know that it's less than 24 hours, and especially if the patient has a renal failure, then you can think that the patient has therapeutic levels of DOAC that can justify specific antidotes. If we have a life-threatening bleeding, of course. If not, then you have to think about how to use the routine test. I would have a normal thrombin time with a normal APTT. I will not run for antidote. But if my APTT with my thrombin time is normal and APTT is normal also, I will not run for antidote for the first. But if APTT is elevated, then you can think about it to administer antidote if you have a life-threatening bleeding, because you know that there's sufficient present to justify it. For prothrombin time, it's the same, but for rivaroxaban and edoxaban. But the problem is, of course, for apixaban. Some centers recommend anti-10I for low molecular weight heparin, so calibrated for that, because they're very sensitive to exclude the presence of them. So my main concern is that these tests are not specific. So in bleeding patient, you will have patient who will have maybe a consumption or dilution coagulopathy, and that will impact also this routine test. And therefore, it's difficult to be accurate in the way you treat them when you don't have specific tests. And then you think about the emergency and the outcome of the patient. And you go through the antidote if it's elevated, and it might help the patient.
Thank you. Anne has just discussed a few minutes ago how can we resume therapeutic anticoagulation after gastrointestinal bleeding. That was one of the questions for Anne. And in general, in life-threatening bleeding, do you have different attitudes regarding the location of bleeding?
Yes, the question is especially for bleeding like intracranial hemorrhage, who can have important, a worse outcome if you start too quickly, the anticoagulation, the therapeutic anticoagulation. So in the literature, you find different approach. There are publications that say that the best benefit ratio was around 7 to 8 weeks to restart anticoagulation. Many others say around 4 weeks after intracranial hemorrhage, you can start the therapeutic anticoagulation. But in some cases, like German registry that retrace to these, they have a low tendency to have a decreased, a tendency of to have a lower thromboembolic events when they start anticoagulation after 2 weeks compared to 4 weeks. So this question is still debated, and we need still further studies to be accurate in this answer. Especially when you know that patient who has anti-vitamin K and have mechanical valve prothesis, there has a high risk of thrombosis, and for these people, the question is to start anticoagulation around 6 days to 14 days. So it can be possible to do it earlier, but you really have to assess the bleeding risk and especially the thrombotic risk of the patient.
And is it different when patients have preventive doses of DOACs?
Yes, preventive doses, of course, if every factor is controlled, hypertension is an important factor, and they can start preventive dose around 2 to 4 days after the intracranial hemorrhage has been already described.
Thank you. Another question. How to manage patients with DOACs and trauma-induced coagulopathy? So
this was my point in explaining why routine tests are not easy to monitor patients who come with a polytrauma, because routine tests will be affected by coagulation-induced trauma. And therefore, again, specific tests are the only way to make the difference between both. But if you don't have them, the first thing is to know that giving antidote is not will not be the only solution to stop the bleeding of this patient. You have to be aggressive with other treatment, depending, of course, if the patient has a severe life-threatening bleeding. So based on this, you have to think about the impact an antidote can bring you, but you don't have to forget that if the patient has severe bleeding, you still need to be think to the antifibrinolytic drugs, of course, in polytrauma patient, and also with aggressive blood transfusion. And don't let too much time to go to the important part from trauma-induced coagulopathy.
I have a question regarding the last part of the answer you just gave. Are you sure that one dose of antidote is enough?
No, there have been many. There have been case reports describing that one dose were not sufficient. That's why it's important to assess. Even if you don't wait for the results before giving the antidote, just take your coagulation tube and ask for a specific test if you have it. Because even if you give the antidote, you can follow. And when the patient has very high concentration, it might be not sufficient. And some people have really required a second dose for that.
And I have another question for you. We had so many questions regarding this topic and this talk. Can we use point-of-care devices to manage bleeding related to DOACs?
Point-of-care devices can, of course, have a place when a laboratory or when centers doesn't have specific test. Point-of-care devices like viscoelastic test can have a place in situation where you have therapeutic levels of DOACs, but they are not very sensitive to detect low plasma concentrations. Therefore, we have to be careful. But it can also follow up the effect of the antidotes. So there is a place, but it's not specific. There's a high intra-individual variability, and you have to know it when you use it. That's the main point. And for the rest, there have been Coagulopathy and ACT devices that has been used to rule out low levels of DOAC concentration. They are not every point of care is not perfect, but for some specific indication, they can rule out thresholds, plasma concentration below 100 nanogram per ml. And in stroke centers, they use this Coagulopathy to give thrombolytic drugs.
So in other words, these devices are available today in, let's say, all the hospitals in Europe, or is it?
I would say that in many hospitals using cardiac vascular surgery or catheter ablation, they have, of course, ACT devices. It's ACT+. It's important to know which one it's used. And of course, they're not perfect, so you have to be careful. It's when you have not the specific test, and or you will go very quickly. Some urine kits has also been proposed, like DOAC dipstick, and this has to be assessed in the real life.
Thank you very much, Sarah, for this beautiful presentation. Very comprehensive and very important for us.